Welcome back, students. Hopefully you are ready for lecture 2 of the cell. And this is our final lecture that I'm giving you for this week. So that it would be a total of 3 lectures, one on your patho intro, and then 2 lectures on the cell. And then after watching these, hopefully you are well prepped to complete your Engage series that we have this week. And reminder, we've got 2 modules this week. This is the only week we're going to have 2 modules, but it is the foundation level for this course. And hopefully we get you ready. Thank you. Let's get started. All right, so we've got part 2 of the cell. All right, so let's start off with inflammation. It is complicated because why not? So quick comparison cable. So here's our 3 main inflammatory markers. We've got cytokines, which are proteins, prostaglandins, which are lipid mediators, and histamine. So these are your 3 main inflammatory players. Cytokines are proteins. There's quite a few different ones. These are the main ones: interleukin, interferon, tumor necrosis factor, chemokines, and you see how he's got his little arrow. That'll make sense here in just a second. And colony stimulating factor. I want you to remember that cytokines are proteins. So I got a little finger with a string tied on there. Cytokines are proteins. They can be regular proteins or glycoproteins. And if you remember from our last lecture, cytokines, we've got this inflammatory alarm system, the first stage in the stress response. So cytokines are proteins. When they're on the move, we've got chemotaxis. So this is a subtype of cytokines, and I always think of taxis. So they're taking our cytokines to other places in the body. A little bit of inflammation is a good thing because we want our proteins and our inflammatory markers. We want them to respond to an injured area. So a little inflammation is a good thing. They come down here and they fix the boo-boo. However, too much inflammation damages things. So students, we talked about this a little bit before. So when you have constant inflammation or a constant insult for more than 6 weeks and your body is trying and trying and trying to protect itself, keep itself at homeostasis, when that goes on for a long time and you have all this inflammation, well, then it gets more severe. Your body does make cellular changes to try to protect itself. Then we've got another example here. So we've got the HPV virus. We've got our cytokines here. Now, normally, when you get HPV, whether it be in your mouth or throat or your cervix, wherever you've picked it up, most healthy people can clear it on its own. However, HPV, and there's like 50 different types. HPV, specifically 16 and 18, can be more challenging for the body to clear. And when they hang out for a long time, then it causes some cellular changes, specifically dysplasia, and then it can cause cancer. So let's look at this. So we've got our cervix right there is where it likes to hang out, causes dysplasia. So plot twist with high risk HPV. We talked about most people do clear it on their own. However, high-risk strains of HPV, especially 16 and 18, are incredibly sneaky. They have evolved ways to hijack and suppress the cytokine response. They block histamine, the release of interferons, which are antiviral cytokines. They shift the local environment to be immunosuppressive. So because the emergency broadcast or our alarms are muffled, then the immune system doesn't clear it. So the virus hangs out. The clinical result is the virus sticks around, causing a chronic, smoldering, low-level infection. Over years or decades, this chronic viral presence and altered inflammatory state causes cervical cells to mutate, which is dysplasia, and can eventually lead to cancer. Students, we do have a very effective HPV vaccine. It covers different strains of HPV, specifically 16 and 18. The reason why we vaccinate women and men is this can also cause throat and oral cancer. HPV can sit on a surface for a while and be transferred. So like if, like if people share towels, which I know sounds gross, or I don't know if you've ever seen like a boys' locker room. It is one of the most disgusting places on the face of the earth. There's towel wrapping and just a whole bunch of gross stuff. So boys can pick up HPV pretty easy and then transfer them to their girlfriends who then can get cervical cancer, which is not a desirable outcome. HPV also causes throat and oral cancers. It's one of the leading causes of throat and oral cancers. So we vaccinate both sexes to try to prevent cancer. Stress affects a lot. So stress affects our body, students. I'm sure some of you have experienced some of this. So if you have long-term stress, chronic stress, it can cause your arteries to get harder, which is called atherosclerosis. It causes a slowing for some people. Their stomach doesn't empty as fast. Some people get the nervous poops. Some people get constipation. Some people waste away to nothing. Some people, even their bone density gets less. Headaches. I'm sure a lot of you guys have had headaches with all the stress of college. Chronic pain, impaired fertility. So let's talk about immunity. So we got two branches of our immune system. We've got our innate immunity and our acquired immunity. So innate immunity, you're born with it. So that would be your neutrophils, your macrophages, monocytes, basophils, and eosinophils. And so I've deliberately color-coded these through the lecture to help be a visual trigger. Your neutrophils, they are fast. They are at the scene of the injury within 5 minutes. They are just trucking right along right there. They don't live very long, 5 days max, usually in the blood volume. In your circulation, they only last about 12 hours. But if they're in the tissues and some other places, they can live up to 5 days. So neutrophils are fast and furious. And I also they are multinuclear. So they got lots of nucleus in there. Macrophages and monocytes. I've made these pink like a pig. Macrophages and monocytes, they're the same cell. They're just called different things depending on where they're hanging out. One lives in the bloodstream, one lives in the tissues. Remember, big, macro means big, phage means pig or eat. So they are big pigs. Their whole purpose is to eat until they blow up. In my next life, I want to come back as a macrophage because I want to be a big pig and have my whole purpose in life to just eat and eat and eat to my enjoyment until I blow up. That sounds pretty awesome. All right, so here is a cute little graphic I made. So we've got monocytes. They're called monocytes in the blood vessels. So if you're looking at your patient's blood work and you see monocytes, that means they're piggies in the bloodstream. If you are looking at other literature and it's talking about a macrophage, still the same cell, but it is your piggies in the tissues. So macrophages and monocytes, they're just eating a whole bunch of pathogens and broken up cells and everything. It just depends on where they're living. All right, your basophils, they actually dye blue on a stain. So I dyed them, or I made it blue here. Think of histamine reactions and anaphylaxis. So we've got our Claritin, we've got our EpiPen. When we need to use these, it's because our basophils are elevated and they stain blue. We've got our eosinophils. Eosin means red, so these stain red. They are elevated when we have parasites in worms and just ew. A little bit elevated in allergies too, but mostly we think of parasites and worms. So eosinophil, it eats parasites. Eosin, it's red. That's what red means, and elevated in worm infections. And that is the true reason to have ivermectin. People like to take ivermectin because it's trendy, and that's what TikTok influencers are saying right now. But really, unless you've got like worms or parasites, you don't need to take any ivermectin. And then we have dendritic cells. These guys, they kill pathogens. They live in a lot of different places: tissues, lymph nodes, and skin. Here's our happy little dendrites, and these are the different places that they live: soft tissue, lymph nodes, and the skin layers. All right, let's move on to the other branch of immunity. This is your acquired immunity. So we've got our cute little dude here, but he had to be gifted this immunity. He wasn't just born with it. It's a present. So we do have these cells in our body, but they have to go to school and learn things in order to be functional. So we've got our thymus academy, and we've got our B cell school. So our T and our B cells, which are a part of our acquired immunity, they have to go to school and learn how to work. So our T cells, which T means thymus, I got thymus written right here. They their origin is in the bone marrow. They are a type of lymph tissue. They mature in the thymus, and they're located in your lymph nodes, your spleen, and in your blood. Cell-mediated immunity, and they do kill things. They work with the cytokines, and they do have memory. So the more things they kill, the more things that they learn, the better they work. Then we've got our B cells. They also originate in the bone marrow, like a lot of our other blood cells. They are considered a part of the acquired immunity. They're a lymphocyte type of immunity cell. They also hang out in our lymph nodes, our spleen, and our blood, and that's what makes our antibodies. So they go to Bone Marrow Academy and they learn things and they make our antibodies and they have memory. So the more times your immune system is challenged, the more vaccines you get, the smarter your B cells are going to be and the quicker they are going to be at protecting you. So these are your snitches. So what are your snitches? So you've got your B cells, your dendritic cells, and your piggies, your macrophages, and your monocytes. These are your snitches. So what do I mean by that? They tattle on what they found. So these cells kill or eat whatever, and then they bring it to the T cells. So cytokines are then released, and then your T cells will show the B cells if appropriate. So what does that mean? It means they are an antigen presenting cell. These cells right here are antigen presenting. So they kill and then they snitch. And snitching means that they're going to take a part of whatever they've killed or eaten. They're going to bring it over here to the T cell and be like, hey, look at this thing I found. Do something with it. And the T cells are also either they're going to kill it, they're going to learn from it, and then sometimes they chat with the B cell, and the B cell makes antibodies. So monoclonal antibodies, these are laboratory created clones of human antibodies. So it's created in a lab and we try to make it kind of like a B cell. It's not super specific, but they do make it targeted to certain tissues. They inhibit a portion of the inflammatory response, so it's really handy when the body's attacking itself. Some examples, we've got rituximab, adalimumab. So some of these are human variants or human, like pretend human cells. If it's a ZU, it's pretend human. If it's a XI, it's actually mouse derivative. So sometimes when people are on Rituxan or rituximab for a while, the body starts to recognize, hey, this isn't human, and then it doesn't work, and then we have to do a more expensive drug. So can we do tests for inflammation? Yes. Here's our main two players. We do an ESR level and a CRP level, which we usually draw those in a lavender top tube and a green top tube. Our ESR, it measures how fast the RBCs fall. It's actually a pretty good test. It's non-specific, but it's good for inflammation, infection, and cancer. Our CRP, it rises and falls faster, so it is a bit more accurate than what our ESR test is. We do usually draw them together. It is CRP, which is C-reactive protein. It's a byproduct of the liver, and it's good for checking for bacterial infections, autoimmune responses, and heart disease. So what do they measure? Cancer-specific antigens, chronic stress proteins like hormones and enzymes, and tumor-specific antigens like cytokines. So some things that we look at, we've got hormones, which can be increased in certain chronic stress issues and cause Cushing syndrome, obesity, hyperthyroidism, and tumors. Protein CRP. These are another things that we can draw in, blood tests. Our BNP, that's elevated in congestive heart failure. CRP can be elevated in liver disease. Your cytokines are elevated with inflammation, autoimmune diseases, and cancer. We've also got tumor markers that we can draw, so like our PSA, our prostate-specific antigen, if you've got prostate cancer, or a CA-125. We'll do this with breast and ovarian and pancreatic cancer. We'll draw this not usually as a screening, but if you have these, like one of these three cancers, we'll draw it just to kind of use it as a measurement also of where you're at in that disease process. All right, so moving on. So we've got blood cells in our body. So we've got these are immune cells that are in our body. These are part of some of your white blood cells that are in your body and fight infection. So our neutrophils, I want you to think bacterial. If your lymphocytes are elevated, I want you to think viral. If your macrophages or monocytes are elevated, that can be either basophils, allergy, eosinophils, parasites. So if somebody comes in with bacterial pneumonia, their neutrophils are going to be elevated. If they come in with mono or some other virus, the lymphocytes are going to be elevated. If they've had that virus or illness for more than 3 days, then our monocytes are also going to be elevated. Just remember, students, your piggies, they don't get there too fast. They take about 3 days to get to 3 days to get to the scene of the accident. Your neutrophils are fast. The pigs aren't. They love to eat. Takes them a little bit to get there. So that can be handy when you're looking at blood work. And if you see that both the neutrophils and the macrophages or monocytes are elevated, you know they've been sick for a few days. Alrighty, roles of genetics in disease. So we've touched on this a little bit with our last lecture. Just a reminder back from anatomy and physiology, mitosis is normal cell division. Meiosis is when we're trying to get or when we're making daughter cells. So this is like sperm and egg division. So when those are the end product of meiosis is just half of a chromosome because that's going to meet up with a sperm or an egg, and mitosis is everything else. So remember, things can go wrong. So we've got transcription errors with RNAs, protein folding can go wrong, or genetic mutations. A reminder with meiosis, the reason why we have that is so this way you get half of your DNA from dad, half of your DNA from mom, and then you get you. Mendel, we touched on this a little bit with our earlier lecture. Mendel proposed 3 laws of genetics that describe how characteristics are inherited from one generation to the other. So we have the concept of dominance. So one allele, which is one version of 2 genes, has dominance over the other. The law of segregation. So fair parenting, each parent gives only one allele of each gene. Law of independent assortment. So alleles from different genes are separated so that they get passed down and that there is genetic variation. And it's gametogenesis. I call it gametogenesis, but that's not a proper way to pronounce it, is making the gametes, so reproductive cells. So students, when you've got dad's DNA here, it doesn't just rip in half and specifically half go over. You kind of get a mixture. They kind of mix it up a little bit. So if dad's carrying, if he's got hazel eyes and he's carrying like a blue eye gene and a brown eye gene, it's anybody's guess what allele he's going to pass down to you. If inherited, so your Mendelian patterns, you've got autosomal dominant, so just one parent, autosomal recessive. So what does that mean? So when talking about your alleles, some are dominant and some are recessive. So if your parent gives you a dominant allele, then that's what's going to win and that's what's going to present. So if one parent is affected with the disorder, each child has a 1 in 2 chance of inheriting the altered gene. Also, each child has a 50% chance of inheriting a normal gene and being unaffected. So key features: the disorder typically appears in every generation, vertical transmission, males and females equally affected. So examples of Huntington's disease or Huntington's chorea. This is a sad disease. If you've got some free time, look that one up. High cholesterol, autosomal recessive. So if it's a recessive, you can still pass it down, but you've got to have a couple of recessive genes for it to really present because it's just not as strong. So both parents are carriers. Each one has an altered gene, but both unaffected. The child has a 25% chance or a 1 in 4 chance of inheriting 2 altered genes from one parent and being affected. Each child has a 50% chance of being a carrier, and each child has a 25% chance of just inheriting normal genes. So examples are cystic fibrosis, sickle cell anemia, and Tay-Sachs. And here are our genetic inheritance patterns. Some examples, we've got Down syndrome, hypertension, Fragile X, and some cancers. So remember, lots of things can go wrong. We can have a transcription error, a misfolded protein. That can just really screw up a lot of things. Make sure in ATI students, I want you to watch the video on ATI in regards to epigenetics. Remember, epigenetics factors do not change the person's DNA. It just triggers the DNA to react, or the person to react in a certain way. Epigenetics can lead to cancer. So carcinogenesis, the process where healthy cells turn into cancer. Chromatin is a structure located within the nucleus of the cell and composed of DNA wrapped around proteins called histones. So we've got our little histone protein. Here's the DNA wrapped around it. That's a chromatin structure. Genetic risk and what to do about it. Sometimes as nurses or providers, we will have set the patient up to do a genogram. So we will look at family history and see what people in the family have certain genetic diseases. So if somebody is in for genetic counseling and they are concerned about, if they are concerned about sickle cell anemia and transferring that to their children, they'll do a genogram and they'll look at the whole family, who has a carrier, who's carrying this gene, who actually has full-blown sickle cell anemia, and what the risk is of passing that on to kids. So another thing that we will do with genetic counseling is sometimes we will do an amniocentesis. So this is ultrasound here, and we take a great big needle, we go in, we take out some amniotic fluid, and then we look at it under a microscope. Some other tests that we can do, these are blood tests. So we can do an alpha fetoprotein that looks for neural tube defects like spinal bifida. These are some other tests that we can look at, inhibin A and human chorionic gonadotropin. This would suggest maybe Down syndrome. So this way parents can better prepare. If they know they're going to have a child with Down syndrome, they can make some better decisions. Or if they know they have a child that's going to be born with a neural tube defect like spina bifida, they can be better prepared. So congenital anomalies. So why do we look? Congenital anomalies. Well, it impacts a lot of mortality in the U.S. Approximately 20% of all infant deaths in the U.S. are from a birth defect. So we want to look at it and do appropriate genetic counseling, appropriate preparation, so that we can take care of things. Teratogens. So this is stuff mom is exposed to that causes birth defects. Teratogens can cause miscarriage, preterm labor, stillbirth, and birth defects. So look at that. 4 to 5% of birth defects are because of things mom was exposed to in pregnancy. Timing matters, depending on when something is being developed and then mom's exposure. That's usually what gets screwed up. So we have conception here, 3 to 4 weeks, nervous and circulatory system starts to begin and kind of goes on from there. So here's an example. These are thalidomide babies. So these are babies that mom took the thalidomide, which was given for nausea during pregnancy, and that actually affected fetal development. So right when these things were starting to form. So if you look right here, week 5 and 6, you got these little nubbies coming out. When you're in mom's belly and you're starting to develop your hands and feet, they actually don't form all at once. You actually start with like little hands that kind of come out from your shoulders, and then the arm grows later. And so if mom took thalidomide when you only had little hands, then that's all you got. But if you got a little bit more of an arm before mom took thalidomide, then you got a little bit more of an arm. So thalidomide was approved in these countries: Germany, the United Kingdom, Canada, Australia, and some others. Our hero here in the US was Dr. Frances Oldham Kelsney. She was a Canadian-born pharmacologist, and she was a physician at the FDA, and she absolutely refused to approve thalidomide, and she got a lot of backlash because of it. Gosh darn, women in medicine, she wouldn't approve it, and the drug manufacturer really pressured her a lot, but she didn't. And you know what? Thalidomide wasn't approved in this country, and so we don't have as many cases here as they do in the UK and Germany and other places. Other things that we counsel women to stop or be aware of as nurses is something called toxoplasmosis. It's a parasite. Sometimes it can be found in cat poop because the cat has ate the toxoplasmosis. And so we don't want pregnant women who, especially if their cats go outside, we don't want pregnant women emptying out the litter box because this can affect baby. So we want them to either wear gloves or have somebody else do that. Other things that we counsel our pregnant moms on is we want them to make sure and take a lot of folic acid. We have found folic acid deficits can cause neural tube defects or spina bifida, especially early in pregnancy. Um, if we know somebody is planning on getting pregnant or wanting to, we actually have them start taking prenatal vitamins before they conceive. This way we can get mom's folic acid levels up high enough before she conceives. Because a lot of times the spinal cord and when spinal bifida starts to form, that's formed before mom even knows she's pregnant. And so it's really important to counsel expectant moms or moms who are wanting to have babies to take folic acid so that we can help prevent this. This is actually why we put folic acid in cereals and breads and foods that are commonly eaten by people. This way we can get the folic acid levels up in women before they get pregnant. Other things we counsel moms on doing to help make healthier babies: lead pipes. So lead is really bad in babies. So lead is in some old toys. Lead used to be put in paint to make the paint color stay brighter and stay better longer. So it's in old homes. Lead is in paint of old homes. It's in old toys. Um, counsel There's a garden here, so it is in soil. Patients or when you're counseling moms and parents of children about lead paint and the dangers of lead paint, counsel them not to, if they build a garden and they've got like an older home, don't put it along the outside of the house because that's where lead paint would have fallen off and there would be a lot more lead in that soil around the house. So have them build a garden away from the house, and a raised garden is better because then this way it's not in the soil that's maybe picked up a lot of lead. If they live in an old home, there might be lead in the plumbing or in the pipes. So, I mean, they might be, giving their kids bottles made from tap water, and so there might be lead in that. So that would be bad. Another thing I'd like to point out, and this is why I put this here, was a mug. So, pottery is awesome. People make a lot of homemade, beautiful pottery things, but especially if it isn't glazed, students, there could be lead in that and it could leak into that. Composting is very, very common with gardening, and a lot of old newspapers and some newspapers, sometimes they've got lead in the ink. And so if they're using paper to compost and use that for fertilizer or compost with their garden, they might inadvertently be putting lead into their garden. The reason why lead is such a terrible, terrible thing, lead in the body, lead and calcium look very similar. Your body has a really hard time telling the difference between the two. And for most adults, it's not great, but it doesn't make too big of a deal. But for small children that need lots and lots of calcium because they're building their bones and they're building their brain and they're building all these important things, if they have a lot of exposure to lead, the body will take the lead and put it in places where calcium is supposed to be. So that's why we make a big deal about lead exposure in young children and pregnant moms. All right, let's go on to neoplasia. So a few definitions. Proliferation, that just means multiplying in excess, whole bunch of it. Dividing, multiplying, and see how they all look the same. So that is proliferation. Differentiation, we've got our stem cell and now he's grown up to be different things. So differentiation means it's grown up to be different things. So remember the first 2 weeks, it's nothing but a whole bunch of proliferation. We get a whole bunch of cell division, and then we get differentiation, endoderm, mesoderm, ectoderm. And then the more differentiation you have, the slower that cell division is. Alrighty, so normal cell life. So we've got our healthy cell, then it starts to shrink, and then it's like, gosh, I've gone past my expiration date, and then we have apoptosis. And then the piggies, your macrophages, come over here and eat this up. So remember, most of the cells in your body have a pre-programmed cell death. So our red blood cells are supposed to die after 109 days and then be cleared out by the spleen and the liver. And then you guys probably already know your cells of the heart, those are supposed to live forever. We want your heart to go on for the whole life. All right, so cancer, why do we make such a big deal of it? Because it's prevalent. So U.S. cancer risk, men have a 40% chance of developing cancer in their lifetime. Women have a 39% chance of developing cancer in their lifetime in this country. Malignancy, that's cancer cells. We've got malignant cells invading healthy tissue around it. This is the difference between malignancy and metastasis. So malignancy is cancer cells invading nearby tissue. Metastasis is now traveling to a different tissue, a different site. Ischemia and infarction, this is the difference between the two. Ischemia just means partial blockage, so you still have some blood flow getting through. Infarction is it's completely blocked. And so why do I mention this? Well, sometimes you'll have a tumor and maybe it isn't metastasizing right there, but because of the tumor size, it's pushing on a blood vessel and it can cause ischemia or an infarction. So the difference between neoplastic growths. So benign means the growth stays put. It's not cancerous. It grows slowly. Usually isn't too big of an issue unless it gets too big and it starts pushing on things that we don't want it to, and an interrupting blood supply. Usually has a well-defined border. It's more annoying, can sometimes cause problems. Malignant, that's the bad thing. Malignant is awful. It is a growth that spreads and invades. It's cancerous. It grows rapidly and uncontrollably, metastasizes, and it can be life-threatening. Oops, there we are. So we've got our benign and our malignant. And so we've seen this slide already. Neoplastic growths just mean abnormal growths. Lipomas are an example of a non-cancerous, just annoying growth. And then we have malignant tumors, which are cancerous, like breast cancer. So proliferation, your neoplasm, and abnormal differentiation. So cancer cells, they're very selfish. So cancer cells, once they start growing, they proliferate. So breast cancer or breast tissue, for example, is normal healthy breast tissue. I'm pointing there like you don't know where they are. Normal healthy breast tissue is only supposed to regenerate at a certain rate, but cancerous breast tissue reproduces faster, so it proliferates faster. Then it doesn't have the normal apoptosis or apoptosis. When it was supposed to die, it's too selfish to do that. It stays alive. Third, it also tells the tissues around it, hey, feed me, I'm really hungry, grow more blood vessels to me. And cancer tricks other tissues around it to feed it so that it gets nutrients and iron and oxygen and all of those things. So we've got our differentiation, primitive cells, and metastasis here, blood vessel. Alrighty. So human development, conception to 20 weeks. This is just kind of a quick little graphic here. So we've got conception. We talked about this already. First off, you just have a lot of proliferation, then a little bit of differentiation. So this is when cell division starts to really slow, and then it slows a lot more. So the more definitive and mature that tissue gets and more defined, the slower the growth is. So why does this matter when it comes to cancer? Again, students, I'm not an artist. So here we have a woman and she has breasts, and here's breast cancer. So if the cancer starts growing early in the germ layer, that cell division is really, really fast. So that cancer is a very fast growing cancer. If there's more differentiation, then it's growing slower. So why does that matter? For example, with breast cancer, if the tumor or the cancer starts developing here, it usually isn't a mature enough tissue to respond to estrogen, progesterone hormones. So this is a more aggressive cancer and it grows faster. If it's a breast cancer that responds to hormones, that's actually a good thing because then we know that normal development at least lasted to here and then it got, and then it became cancer. So it was mature enough to start responding to hormones. And so it's a slower growing cell division or slower growing cancer. So if we have a breast cancer patient and it's what we call hormone responsive, well, that tells me it's a slower growing cancer because that tissue is grown up enough, mature enough to start responding to hormones. Another thing to keep in mind, students, viruses can cause cancer. So here's some examples. So H. pylori, this is a bacteria that can cause ulcers, but if untreated, can eventually lead to cancer. Hepatitis B, we usually vaccinate for this, and the reason why is one, it's a pretty nasty virus, and two, it can cause liver cancer. HPV, we vaccinate for this. It causes genital warts, which are not becoming to anybody, and it can cause cervical cancer. Mono, we don't have a vaccine for mono yet, but it can cause lymphoma. This virus is actually where we learned that viruses can cause cancer. And if you want to learn more about herpes and mono, I actually have a separate video that you can watch. Just let me know. And you can learn everything you want to about herpes. So mono is actually a herpes virus. It's one of 8 herpes viruses, and it can cause cancer. And HIV can cause Kaposki's sarcoma. But it's natural. How could it be bad? Because natural is the trendy thing. So here is some examples of natural things that cause cancer. Wood dust, asbestos, nickel, radon, uranium, crystalline silica. So that is very common in dirt and rocks. I do want kids to play in dirt and with rocks, but just know that this is in it and that can cause cancer. So you've got your 3 germ layers, quick reference. These are what they make. ATI talks about primary, secondary, and tertiary protection. Primary prevention, this is everybody. We do vaccinations, have you eat healthy, and this is to protect everybody. Primary, everybody across the board. Secondary prevention, this is more specific. So you're a woman, you have boobs, you're at risk for breast cancer, or especially if it runs in your family, we're going to have you come in and get some mammograms so that we can screen you for breast cancer. Tertiary usually means you already have it, and now we're trying to make your side effects or your symptoms of that less miserable. Cancers by histological type. So we classify our cancers. We don't just say, "Oh, you have cancer," and then just say it's cancer. We label it by the tissue type or histological type, and then we also grade it and stage it. So we're going to go over that now. So carcinomas. So depending on what tissue it comes from, depends on if we call it a carcinoma, sarcoma, lymphoma, leukemia, etc. So that's what we're talking about now. So carcinomas, they come from epithelial tissue, the ectoderm and endoderm. This would be breast, colon, prostate, skin cancer. Sarcomas, those come from connective tissue, which comes from your mesoderm. So that's your bones, uterus, pelvis. Lymphomas, which come from your lymphatic tissue, that causes, Hodgkin's and non-Hodgkin's lymphoma. Leukemias, there's different types of leukemias that comes from your bone marrow. And then you got some others like your brain cancer. Mesothelioma, that's asbestos related. Quick memory rule, if the word ends in oma, it's a tumor. If it begins with carcinogen or carcin, it's an epithelial in origin. Sarcoma, that would be connective tissue. Emia is blood. So like leukemia is blood. It's a blood cancer. Side-by-side comparison. So we talk about staging and grading when we're talking about cancers. Staging is how far it's spread, and grading is how abnormal the cancer cells look. So it answers the question, where is it, or how aggressive it is, staging or grading. And the tools used, well, we do imaging. We do CAT scans and MRIs and PET scans and biopsies, and we look at it under a microscope. So let's delve in a little bit further. We've got staging. So most cancers in this we label them by the TNM system. So tumor, which stands for T, nodes, how many lymph nodes are involved, and metastasis, has it spread just locally or distant. So we've got the size of the tumor, which is T1 or T0 through T4, lymph node involvement, and how far it's traveled. Combined stages. So we've got stages 1 through 4, small, and the bigger the stage, the more it's metastasized. Grading, how aggressive is it? Low. The cells look mostly normal, so they're well differentiated, so it's a slow growing. And as you get to a higher grade, it's completely undifferentiated and most aggressive. So we can come back here to my drawing. So it just kind of depends on when things went off in the ditch. If tissue was, if the tissue was developing normally and got almost to final mature tissue, but kind of went off in the ditch here, well, then it's probably a pretty slow growing cancer. But if it was over here, then it's a fast growing cancer. Let's come over here. Okay. Staging, so that's the map. It tells you where the cancer is. And grading is kind of the mugshot. Tells you how mean or aggressive it looks. Side effects and complications. So when you are sick with cancer, you are not just sick with cancer. That you have other problems. So issues that can happen when you have cancer, in addition to the tumor, pathological fractures. So weakened by tumor invasion. So if you have bone cancer, for example, you don't just have a tumor in your bone. It is weakening that bone. It is taking calcium from your bone. A lot of cancers like to have calcium. And now you can get a fracture there. So like it's not just that you have a tumor there and you need to treat the tumor. Now you can have a fracture. You can have bone pain, hypercalcemia. Like I said, there's a lot of cancers that like calcium. Neurological, you can get encephalopathy, you can get seizures. So if you have brain cancer, it's not that you just have a tumor in the brain that needs to be taken care of. That tumor is growing, it's cutting off blood supply, it can be causing seizures, it can be causing inflammation. So now you've got encephalopathy. It's causing other problems, not just cancer. Chemo brain, oh, this is so true. A lot of the chemo drugs that we give are incredibly strong and it can affect mentation. Respiratory issues. Well, if you have lung cancer, it's makes it harder for your lungs to work when you've got a big tumor sitting in the way. You can start coughing up blood. That tumor can press on the superior vena cava. Gastro cancers or GI cancer, stomach cancers. It makes you're not hungry. You got a tumor sitting in your stomach, so it screws up your appetite. It can cause a bowel obstruction. It can cause fluid to accumulate in the abdomen. Nausea, vomiting, anorexia, dysphagia. Students, when we talk about anorexia in cancer, it's not because they don't want to eat. Anorexia nervosa and like true anorexia, they're two different things. So anorexia nervosa is somebody who views themselves as fat all the time and they're like scared to eat because they're scared to gain weight. Anorexia in regards to cancer is they want to eat, but they just don't feel hungry at all. Hematological issues. So with some of your cancers, it really screws up your blood vessels and it causes chronic iron loss. So it causes some anemia. Cancer causes blood clots in a lot of people. It screws up your like normal clotting mechanisms. It screws up your white blood cells, so now you're at more risk for infection. Metabolic endocrine issues, it can cause your blood sugars to go out of whack. It can cause your calcium levels to go out of whack. Immune issues, it causes fever, night sweats, fatigue, immunosuppressant. Cancer screws up a lot of things. It really messes up your body. Quick tip for students. So these are things that cancer can screw up that I want you to remember. So it can cause compression and invasion in nearby structures. So it can cause ischemia, infarction, pushing on stuff. It can cause abnormal hormonal secretion, and it can cause systemic inflammatory response just because the tumor's there. When it comes to medications, when we give somebody chemotherapy for cancer, we don't just usually give them, we don't usually just give them one drug to kill the tumor. We treat a whole host of different things. We will give them a chemo drug uh, that screws up the blood vessels that cancer is telling it to feed. So let's just, we're going to say this is a tumor. That tumor is growing there, and now it's pushing on different things. So I'm going to give a chemo drug to kill this and shrink the tumor, but I'm also going to give another chemo drug that's going to screw up the blood vessels that is feeding it. So I'm going to choke it off. Okay, so that's another chemo drug. We're going to give radiation to kill the cells around it so that if it was starting to metastasize, it's going to kill those things off. So cancer treatment and cancer therapy is very complex, and we treat different aspects of that tumor. So, all right, this is the end of your second cell lecture. So now you've got all 3 lectures. Now you're ready to. This should give you a good foundation to start your ATI and move through that. If you have any questions, let me know. Thank you.